All right, good morning or afternoon, everyone, depending on what time zone you're in. Thank you so much for joining us today for our sixth Fireside Chat with the ED Stop Suicide Quality Improvement Collaborative. As always, we just begin with a quick acknowledgement of our funders. The EMS for Children Innovation and Improvement Center is supported through HRSA, as is the Pediatric Mental Health Care Access Technical Assistance Program. None of the contents that are presented today are necessarily represent the official views nor endorsement by HRSA, DHHS, or the U.S. government. So as always, thank you so much for joining us today. We're really excited to welcome the speakers today who will be getting started shortly. As a reminder, just remain on mute during the presentation. If you have any questions, you are certainly welcome to post those into the Q&A feature. This Fireside Chat, like all others, is being recorded, and it will be posted online along with the slides shortly after this event. If you are a nurse or a social worker who is seeking continuing education credits, please make sure you put your first and last name into the chat so we can verify participation or attendance. Following this session, we will have Q&A open, and we will try to address any and all questions that you might have. Those will be addressed primarily by the speaker, but if there are any logistical questions, we can address those as well. And then if you can stay on through the end of the presentation, at the very end, we will have the link to continuing nurse education credits as well as social work credits, and also a short evaluation. So today, we are excited to focus on ED-based interventions, specifically some de-escalation techniques that might be used, patient and family considerations when boarding in the ED, and then some tangible interventions for coping and or establishing a sense of community for those patients with mental and behavioral health emergencies. For physicians, nurses, and mental health professionals, as we've mentioned previously, we are offering continuing education credits for physicians in the form of maintenance of certification that will require an attestation form at the end of your QI project. For nurses and social workers, as I mentioned, our last slide will have a link, and you'll be able to go directly to that to obtain your credits accordingly. So with a focus today on our intervention bundle guide number 3, which is on ED-based interventions, our global aim is that by December 31st, 2023, 100% of the teams that are participating in this bundle will have established a clinical care pathway for children who screen high risk for suicide. We have several measures, we have several measures that have been included in this intervention bundle. Those are found in the intervention bundle guide. But at this juncture, I'd like to go ahead and turn this over to our two speakers. So today we're so excited to welcome Nina Friedman, who was previously an EMS for Children Program Scholar, one of our inaugural scholars, and in addition is a child life specialist in the Pediatric Emergency Department at New York Presbyterian, the Weill Cornell Medical Center. And then secondly, Angela Nguyen, who is the manager for clinical pediatric social work at Dell Medical School here at the University of Texas in Austin, and is also an assistant professor within the Steve Hicks School of Social Work and has done a tremendous amount of work implementing suicide-based evidence-derived clinical care pathways across diverse EDs. So with that, I am excited to turn it over to Nina Friedman. Take it away. Thank you.
Thank you so much, Kate. For those of you who don't know, very quickly, child life specialists are healthcare professionals clinically trained to help children and families cope with and process illness, injury, hospitalization, trauma, disability, and death. I received my training by obtaining my master's in the field of child life. So the educational curriculum is a combination of psychology, social work, medical linguistics, play therapy, and there's a really heavy emphasis on patient advocacy. And then the foundation of the training is in children's development and how to really translate various traumas for children based on their developmental level. And although my master's really focused on mostly medical patients, I've really needed to reassess my own triage of patients to put mental and behavioral patients at the forefront of my practice. And what I mean by this is that my triage is less about medical stabilization and more about emotional stabilization. So if there is a child in our resuscitation room and they're coping very well, I don't need to be in there just because it's a trauma. So this mental health crisis has kind of shifted my focus to caring for these patients and families on a daily basis. So I've had to restructure who I think is important to see, because I really see the fear, pain, and anxiety that the kids with a psychiatric crisis present with, and I really see it in their caregivers too. A child life specialist can help a child and their family to cope with and process, but another side of this is truly being, someone who can really help our nurses and our doctors and other medical team members to navigate a family in emotional distress. One of our attendings in the PEDS-ED affectionately refers to us as human propofol. So that kind of sets up what a child life specialist is. So many of you, like me, have probably been told numerous times that the arrival to the ER is in itself traumatic, and that trauma can be especially heightened when the police or EMS are involved. Not always, but often when a child arrives in the pediatric emergency department for a psychiatric evaluation, that child feels as though their trust isn't broken by the person who insisted they come in. So it's really important for us on the receiving end to recognize how vulnerable children are when they arrive. A lot of kids are here after they disclosed something they've never mentioned before to a therapist, to a teacher, to a guidance counselor, to a social worker. A child in a mental health crisis is not the same thing as a level 1 trauma. There can be just as much chaos, but however, the odds are that the child in a mental health crisis has stable vitals. So that's to say, we have the time, we can make a difference by really changing the power dynamic, by recognizing what this child needs, which is often to have a sense of control. By giving choices and by giving them time, we are setting everyone up for success, both the patients and the providers. And what we're really doing is we're establishing trust. In the ER, we feel like everything has to happen urgently. And for these kids, their minds are going a mile a minute. So what we can do to balance this is really slow down. Policies that exist for patient safety, like changing into scrubs and taking away personal belongings, puts these kids on the defensive right off the bat. So it's important that everyone is safe and that policies are being adhered to. But if that child is in crisis, it's often safer to help them calm down first. Taking someone's things away is rarely the way to make anyone calm down. So I mentioned this before, but changing the power dynamic and giving kids a sense of control by allowing them to make a choice. They're going to have to put on those safety scrubs. They're going to have to give a urine sample, but acknowledging that you see their fear and you see their pain and giving them time can create a safer environment and establish that trust that they really, really need, especially if it's something that's been recently taken away from them. I understand that they don't want to change their clothes, or sometimes it's really more they won't change their clothes. But how about we just start with shoes or removing a jacket? Or how about we let it be their choice, which one those is? And maybe the choice is that they need more time, and that's okay too. Just a quick example I have is we have a teenager who comes into our emergency room fairly often, and she often comes in handcuffs. And I've seen 2 different scenarios play out. One is when she comes in and whoever the staff is there that day feels as though the most important thing to do is not to de-escalate, it's to get her to change her clothes. So they have the police take her handcuffs off, security holds her down, changes her clothes, and then the handcuffs go back on. And then typically after this, she is almost impossible to de-escalate. She rarely calms down in those circumstances without us having to use some sort of like IM medication. On the other side, we've had days when she's come in handcuffs and she's escalated, and the staff has decided the most important thing is de-escalation. So if we give her the time and allow her to calm down, when she does, the cuffs come off, she changes her clothes by herself, the medication doesn't have to be given, And we've set up, a much safer environment for her and for the rest of the staff. Changing the environment is not always available in emergency spaces, but these modifications can be really small and subtle, like turning off the lights or asking someone to step out or away of the bedside. Sometimes caregiver presence is really helpful and sometimes it's not. I think it's really important to let that patient decide. Any choice you can give them, no matter how small, helps them to reclaim a sense of autonomy. I think sometimes one of the only things we can really let a child choose is who is there at their bedside. So saying, do you want mom here or not? And if you don't want mom here, do you want us to tell mom that you don't want them here? Or do you want us to tell mom that we're going to ask mom to step away? And that shows them that we're on their team and we're on their side. Next slide, please. So this is something that I think is really, really important in all of our work. And we hear it at work, but we also hear it in our own lives all the time. Attention seeking versus connection seeking. Asking for attention is often seen as a negative thing. But if a child is seeking attention, what they are really doing is trying to make a connection. And we need to recognize that as what it is, which is a very natural and very normal human need, instead of casting it off as someone who's just looking for attention. These kids feel a tremendous amount of shame, and it can often be very awkward when they're in the ER. They can feel like someone has suddenly shown a light on something that's really dark and that they've been trying to hide. They need to understand that their feelings are valid, but that we can't always control our feelings. But that what we and then that's not their fault. Feelings like SI can be dangerous and they can also be really, really painful. There are 4 things that I found that almost always help to make a connection with a child having a mental or behavioral health crisis. And I have found it helpful when the caregivers can hear me saying this to their child as well. And I say this pretty much to everyone. The first thing is to let people know that they haven't done anything wrong, that this is not a punishment, that I recognize that taking their things away and changing them clothes and putting them in a situation where someone has to sit with them, it feels like a punishment. And I tell them that some kids tell me that it feels like a punishment, but I really want to really get it across that this is not a consequence for something wrong. It's actually what happens when you've done something right, which is asking for help. And I want them to know that it's not about them not allowing to feel their feelings. They're allowed to feel angry. They're allowed to feel worried. They're allowed to feel sad. But what we are asking of them is knowing what they need to do when they have those feelings and how to keep themselves safe when they have them. When someone walks into the ER with a broken bone, we can see where that pain is coming from, right? We can take an X-ray. We can treat their pain, but what we don't do is we don't give that person a stress ball and tell them to take 5 deep breaths and pass them a coloring book and send them on their way. We stabilize the break and we treat the pain. So I want them to know that their pain hurts too, and they deserve to feel stable and they deserve help for that pain. And the 4th thing is that they're not alone. They're not alone in this process. I think we sometimes feel like it's everywhere, and in many senses it is, but a lot of times for children and families, especially when they're coming to the ER for the first time, this is the most isolating experience in the world. And so this whole concept of helping them to not feel alone brings me to the next slide, which is an intervention that I created in the ER. I'm a child life specialist, but you do not need to be a child life specialist to roll something like this out for your patients and families. By really, really wanting kids and families to know that they're not alone, I created this binder. It's a 6-inch thick compilation of letters, artwork, notes, and poems that I started collecting in 2017. All of the entries are anonymous. They can't write their names or where they go to school. I joke about their no social security numbers or TikTok information. So many of the entries are signed using some variation of "love someone like you." So we now affectionately refer to the binder as "someone like you." What is really incredible is that without any guidance from myself, these patients started writing notes of inspiration to one another. Next slide, please. Only children in the ER can add to this book, and only children in the ER can look at it. I let their families look at it too, but I will always, specify if someone wants to add something, I'll ask them if they want their parent or caregiver to see what they've added or not. I think what this binder is sort of a testament to the community that exists among this population. This intervention is cost-free. It's easy to roll out. It's theirs. It's their voice, and they can really hear one another and see one another. Next slide, please. The only thing I do is I screen the entries for anything that's really inappropriate, but I let kids use whatever language they want. And I think that's kind of in the name of self-expression. And in over 5 years, I've really only taken out 2 to 3 entries. I think another benefit of something like this is that in their words and in their artwork, we as providers can also learn from their experience and see a little more clearly into their world. Next slide, please. What I hope everyone sort of takes away from this is that I hope you feel empowered to give these kids the care that they need. We speak a lot in pediatrics to meeting people where they're at and meeting patients where they're at, but to meet a child with a psychiatric crisis where they're at, we have to recognize this type of crisis as what it is. It may look very different from a medical crisis, but it's still a crisis, and it still really hurts, and it's still really scary. And they're still coming to us for help, so we need to treat them. Next slide, please. So I encourage all of you to slow down, give kids time. I know it really goes against every mindset we have in the ER, which is that everything that has to happen must happen immediately, but we need to give choices. And by doing this, we are truly meeting kids where they're at. Thank you all so much.
Okay, so my talk, I'm Angela Nguyen. I feel like I just want to pause and think about that more. That was a great intervention. And so mine's going to get a little bit less fun to talk about. But we'll circle back on a lot of the things that Nina mentioned. So one of the things that we really wanted to capture in this talk is not necessarily telling you, because every state is different, what to do, but just things to consider as you're rolling out your pathways and making sure that staff are educated and that you're putting all the different considerations in. And so some of you know this, and some of you who maybe don't see pediatrics all the time, some of this might be new. But in general, if at the last resource page, we have links to examples of patient bill of rights. So there is specifically for mental health. I think when everyone comes into the hospital, they sign a general bill of health or patient rights. There is one generally for mental health as well. And that general says you have the right to informed consent. You have the right to, evidence-based treatments, things like that. And so making sure that you're investigating in your state, what does that Bill of Rights look like? Does your hospital have one? And it's just kind of slid in during registration and you don't even get to read it. Sometimes in Texas, it's supposed to be left with the patient. So I've had kids highlight, I'm not getting this right. Like, how come I don't get this? And so it's good. So being aware of what those patient rights are. It's getting access to basic rights, going outside occasionally. So if you've had a patient in the ER for 72 hours and they haven't really seen much sunlight, that's a consideration of how do we make sure that they get some movement around, and what is their rights, making sure that they get to have hygiene, so they get to take a shower. So things like that to think about with their rights. And then some states also have mental health versus medical care regulations. So I know some states, once you say that you're aborting a patient, then you have to start following mental health protocols, which might mean that you have to have parents' consent for psych meds. It might mean that emergency medications are different. The same medications given, but it might have a different protocol of what the orders might need to look like, as well as restraints. So I think kind of thinking through those, as well as your hospital protocols and consents. So what consents might change. What is the law in your state of when a minor can consent for their own care? Some states go as low as 16 can consent to their own care. Some are 18. When do you have to disclose information to parents? Who consents for medications? Who consents to hospital holds? So, you know, in some states, a physician can write for a hold to transfer a patient or to have a patient go on to the psychiatric unit. Other times, law enforcement or police have to do that. And so just trying to make that clear of what those steps look like and when to do it. So in Texas, we're not supposed to, technically, we're not supposed to put a patient on hold if the parent is willing to consent. So doesn't make you're not allowed to have them on a hold. So I think kind of working through what does that protocol look like? And then also with consents of divorced families. Oftentimes, psychiatric hospitals are taking away the patient's rights, so they're going into a locked facility. So that means that they often need a higher level of consent than just grandma who doesn't have guardianship. So also thinking about that of, can the minors be in the emergency department without a guardian? Would you prefer that? Or what's the protocol of having a minor if you're not used to having minors in your ER by themselves? And then what's the protocol for transfer of a minor? So thinking about that ahead of time, because I've seen that delayed transfers a lot. And also just assessments of, did we consent the right person to do this assessment and to do the transfer? And if we can't find the person to then accompany them to the transfer, that slows things down. So just thinking of that with your process and your flows. And there's some resources at the end about just the Bill of Rights. So next slide is going back to kind of what Nina was talking about with the trauma-informed care. So trauma, being in an emergency department, means something different to a lot of different people. But in general, it's recognizing that in general, the lens or the practice, the way that we see the patients that we care for, all of them, is in this idea that we don't know what's going on with them. And we don't know the purpose behind the behavior. And so we need to come with it, come to the care in a way that is understanding and recognizing that this could be a trauma response. So their anger may not be about you. It might be being curious about what's actually happening right now that's triggering them. So anything that we do would be to not traumatize or re-traumatize. So I'm thinking of the example that Nina just brought up. And I'm thinking, oh my goodness, that girl probably had some trauma, and the idea how much her body was probably activated and how much she went into fight or flight and how long it took her to calm down when she was being held down. I think kind of that of like, oh, okay, that clearly made things worse and she may not have had control of that fight or flight. And so kind of what does that mean? And then emphasizing safety, I'll go into that a little bit more. Trustworthiness and transparency. I think that's one thing that a lot of emergency department staff talk to me about, because they're really afraid to tell the kid that they're going to go to a psych hospital, because what if we make them mad? Or really afraid to tell them that, making sure that they know that we have to tell someone what they told us, or not telling them what the plan is. And that just adds to the anxiety. So making sure that we are upfront all the time with what we can be. And as Nina said, collaboration and mutuality. So when we can collaborate, when we can give choices and we can empower, it's definitely needed. And then cultural sensitivity and responsiveness. So just kind of being aware, asking questions and staying curious, knowing different power dynamics. So this kind of list was adopted from Johns Hopkins, and Sam said there's lots of different resources at the end, but ultimately adopting trauma-informed practices can improve patient engagement, treatment adherence, and health outcomes, as well as provider and staff wellness. It can reduce avoidable care and excess costs for both in social services and in healthcare. And ultimately, I think I say this in another slide, but it needs to be how we practice with our peers. So with coworkers, as leaders, with our teams, as well as with the patients that we serve. So the next slide is some examples that I found from it, and I liked it. So these are the core principles of trauma-informed care, and it just gives some examples of what that looks like. So these are the 5 core concepts of trauma-informed care, and giving people choice, listen to what they want. So if it's something that's really not worth a power struggle, then just let it go. Be like, okay. An example we had very similar in my emergency department, where a kid didn't want to change into a hospital gown. And we had just done this training on trauma-informed care with our team. And so the nurse asked the patients, like, okay, what are you willing to change? She said, I just don't want to take my pants off or this bracelet. And so she's like, okay, here's what I can do. I'm going to need to do, I need to look in your pockets. So can you do bunny ears? And then kind of, show me this, show that the edges to make sure there's nothing in there. And you can definitely keep the bracelet on. And then I'm going to go find you some scrub pants, and you can put the scrub pants on if you would feel comfortable with that. And the patient was okay with that. She just didn't want, the idea of not having her pants on felt overwhelming, and she was not going to budge on changing into a hospital gown. And so just the nurse problem solving in the moment with the patient allowed her to collaborate with her, and didn't create that power struggle, and gave her some the ability to actually be safe and change her clothes. So kind of thinking about that, and then also with our team, right? So we validate people's feelings, we listen to what they need. We don't come in and tell them what they should be doing, kind of listen to what they're saying and ask them how we're going to work on that together. Okay, so next slide. So this is the safety that I kind of talked about. So this concept is a concept that I think we all know about, but I wanted to kind of go into detail more about it. So felt safety is the experience. It's a feeling. It's not necessarily a cognitive one. So we all know the idea that, whenever you get triggered or you're really activated or upset, it's really hard to access your frontal lobe. And that's where all your good choices come from, right? Like we make strong decisions and executive functioning happens there. So oftentimes we get frustrated with kids who can walk the walk, they can talk the talk, but not walk the walk. So when they're talking to you, like, what are you gonna do next time you're upset? I'm gonna do this, and I'm gonna do this. They get upset, they do none of it. So basically what our job is, it's not to tell the kid, don't worry, I'm gonna keep you safe. Because how many adults in their lives have said that and they haven't been able to follow through? Or they're the ones who actually are the ones that made them not safe, in whatever way. They told the school, they told the school counselor, and the counselor's like, I'm not gonna tell anyone. And then all of a sudden they're in an ER. So we always wanna be transparent with them. If you tell me you're suicidal, I have to take care of you, and you have to go to the emergency department. So the way that we can do that is that we have to arrange the environment and adjust our behavior so that kids feel safe. And so listening to what they're saying and not just counting their feelings or their concerns. I mean, an easy one is, what would make you feel safe right now? If they ask for water, get them water. If it's, can I keep my pants on? Okay, can you compromise with me? Let's work on that. Try to figure it out. So just trying to figure out how to follow hospital protocol, but at the same time, hearing what the kid is saying and acknowledging that. So this concept comes from intervention called trust-based relational intervention. And kind of the way that they explain it as an adult, if you've had felt safety or not, it's just where you kind of have said, like, I know that's true, like in my head, but in my heart, I know it's not. So it's like the kid is like, yes, logically, I hear you saying that I'm safe. I see that I'm in an emergency department and you have cleared everything. I am not going to hurt myself, but I'm still activated inside. I'm still feeling really amped up, or overwhelmed, or whatever's that feeling. So this helps them calm down and actually be able to process and work with everyone. So the other big thing around that is just remembering how the brain functions. So when you see an activated kid, knowing that if you're giving them orders, they're not going to be able to follow it very well. So you have to, I'll talk about co-regulation in a minute, but really calm down, as Nina said, slow down, get on their level, listen to what they're saying, even if you don't agree or can't fix it, and then start being able to talk to them, so that will stop sending messages to their body, you're not safe, because it's a maybe they're not even thinking it, but their body's sending out the chemicals that are showing that they are not. Okay, thanks. You can move on to the next one, Kate. So the next one topic that we wanted to cover, and this is a short talk, so if anyone has any questions, we can talk offline, or I can follow up with different things. But when we were making this presentation, we were talking about like what are some of the things that we really need to consider throughout the pathway, and that come up often. And parents and families just come up often. Sometimes they trigger us, sometimes they trigger the kids. And so, I have to remind myself that probably their worst day ever. And we just have to meet them where they're at. And that's part of trauma-informed care, meaning, their kid just tried to kill themselves and they couldn't stop them. Or their kid is chronically suicidal, or their child tried to hurt them. Like, no one signed up to be a parent to get beat up, or to, have their kid have the shame of feeling like, oh, I can't even parent my kid because they don't want to be alive. So they're going through a lot. They might not show it in that way. They might show it as anger and frustration. This might be the third time they've been to the ER and they're just done with the system not helping them. They might be about to lose their job, or because they're missing so much work because of this. And then we tell them they have to stay in the ER for 72 hours, or we're really not sure how long. They might have some responses to that. So I think the biggest thing that when I've met with parents and we've done like patient family advisory councils, what they need to hear is, you did the right thing. It's really hard to ask for help, and I'm glad you're here, and you're in the right place. Because they're second guessing themselves. Maybe I overreacted. Maybe, is this the right place? As an ER staff, working in the ER for a long time, that might not be what you're thinking, but this is what we need to be saying, because everybody's human. And so if this is the fourth or fifth kid that have came in tonight and you've got an ER full psych kid, or this is a kid you've seen before and you're like, oh, that kid again, we have to own that we have those feelings sometimes. I'm not telling that you can't have those feelings, but we also have to take a deep breath and remind ourselves this, because we might see 5-6 kids a day, but this might be the first time this ever happened with this family, and they need to know you're doing the right thing. We're glad you're here. We're going to take care of you. And that's really what they need to hear. And so, yeah, and I think the other big thing we've usually, when a parent's really activated and they're like frustrated or mad, a lot of times, not when they're yelling at me, but kind of like, let's go talk. How are you taking care of yourself? When was the last time you slept? Making sure that they might have been in offices and transfers, like, have you guys eaten? Like, what's going on? Where's your other kids right now? Are you worried about who's going to take care of your other kids? Just kind of helping acknowledge that the ER visit is not fun for anyone. And we really understand that we want to be here and to be as supportive. And then coming up with processes, knowing what's possible within your team. So if it's mom's freaking out, I don't know who's going to take care of my other kids and I can't leave the bedside. What's your hospital policy for that? Can mom leave the bedside? Is there insurance for a little bit to get him to grandma's house? If there is a grandma, his dad getting off work in an hour, and he can come trade places. What's the problem solving that we can do? And make sure that staff are educated. Because on having that curiosity and that mental flexibility of how can I meet this family where they're at and serve the patient. And that might take a little extra time at the front end. On the back end, it's a lot more helpful. Okay, so next slide. So these are just quick strategies. I want to make sure that we leave time for question and answer if there is any, but these are just catchphrases, things easy to teach your staff, like if you have tips or tricks or things that you want to put together. But name entertainment, I'm sure most of you have heard this. So name entertainment is how you control your emotions a lot of times. So And that's how you can connect. So that idea of, I noticed you got really teary-eyed when you talked about that. Can you tell me more about it? Or do you want to tell me more about that? So kind of just naming that, or like, oh, right now it seems like you're pacing around. Is that because you get anxious and you pace, or is that because you're angry? Like, are you bored? Like, can you help me understand, like, what's going on there? And then staying curious about specifically what's the purpose behind the behavior. And that's something that Nina kind of talked about with, kind of understanding that people are doing things, maybe it's not adaptive, but they are seeking connection. What's going on? So if you're not sure about the behavior, just staying curious and trying to figure out, okay, why maybe will this be happening? Because the next one is everyone does well when they can, or you're doing the best you can with the resources you have. So kind of understanding that. That's one of the big things that me and my team talk about a lot, is no kid wakes up in the morning, it's like, man, I really hope I end up in the ER today, or I wish I hated my life. I want to get in trouble every day and kicked out of school. Like, no one says those things. And so there's always a purpose behind the behavior. People like to do good. Kids like to get praise. So in general, it's there's another reason why these things are happening. And if you can address that, a lot of times that is, you have that connection and you can build that rapport with the kids. Explain what success looks like versus what not to do. So I use this a lot of, like, when, I don't know if you guys ever went swimming as a kid, but lifeguarding, they always tell you to yell, walk, instead of don't run. So think of that. Like, if you want a kid to do something, don't tell them what not to do, tell them what to do. Because a lot of times kids don't know what you're expecting. It's the first time they're in the ER. They don't know if they're allowed to go out to the bathroom without asking for permission, or if they just go. They don't know. So what does success look like? And then playful engagement. So again, it may not come natural. I think it comes natural for most staff who work with kids. But knowing that you don't always have to be gruff. So, often one of the things that I do is I'll be like, well, let's try that again. I'll show you. Miss Angela, can I go to the restroom? And it's like, okay, now your turn. Because instead of being like, hey, I have to go to the bathroom. It's like, oh, really? Let's talk about, or something basic like that. So if it's someone's being just kind of be playful back with them. And then, as they're staying with you for a little bit, give them an expectation of what the routine is going to look like today. I mean, if you wake up in the morning in the ER and you're like, well, what am I going to do? What new people am I going to meet? Because shift changes and all these different people. So kind of having an idea of, like, what does the routine look like? What time do you eat? When will I see the team that's going to tell me if I'm going to leave or not? Do I do any activities? Who help me with that? Just kind of having an idea of, like, what is the day going to look like for me? And then give choices when you can, be honest when you can't. They say, can I have cheeseburgers for all 3 meals? Be like, no, you can't. Is my mom going to come visit? Yes. But as Nina said, you don't have to see her. I can't tell her to leave, but she will come visit if she wants to. That's the truth. And then the halt of when someone's kind of agitated, just always remember, are they hungry, angry, lonely, or tired? So, just, do they need something to eat or drink? When was the last time they had good sleep? And I'm thinking through some of those basics. They're not always major things that you have to think through. Okay, so I will, next slide. I feel like I've been way too talky, so let's go through. I can skip through this a little bit. So the other thing is, the way that we think about things is how we behave. So we know that as well. So changing, just even if we're not saying some of these things to patients, but if we're thinking them in our head, so just the way that we change things. So being kind of modeling for teams, things that you can say, if you hear one thing, try saying something else. So I have 2 different language matters, like links in the resources, to talk about, like, what is it that we could say that can kind of just reframe the situation, or not. The way that you see things is the way you behave. So if you see a kid, like Nina had said, if you say that a kid is attention seeking, you're going to see that as manipulative versus they're attention seeking. And so that's different. This kid is really seeking attention. They want to be close to someone. They want someone to notice them versus this kid's just doing that for attention. Like it's a negative thing. So that's
Angela, can I say something that really quickly? And this thing I say all the time, even doing things for attention, especially in the context of suicide, and I say this to staff and families all the time, it's still really dangerous. So at the end of the day, I think there is this like judgment and this dynamic of, oh, they're doing it for attention, but you can still kill yourself for attention. So I think, you know, it doesn't, I always am saying it doesn't really matter. And I think that's an important thing to remember is doing something for attention doesn't make what you're doing or that action less lethal or harmful.
Right. Or painful. So I think that in one of our, you know, in the assessment that we do, we try to find out, like, were you trying to get attention? Like, that's not a bad thing, but it's really like, that really is trying to get your needs met. Someone's not listening. I have to, you know, I'm trying to do this. I was so desperate to get someone to hear me. Because oftentimes that comes out like maybe when they do something in front of a parent. Well, they were just seeking attention because they took the pills in front of me. Well, at that point, think how, you know, what's the purpose behind the behavior? The kid was so desperate at that moment to be heard and to be seen and to be acknowledged that like only thing that they could think of was doing that. So it still needs treatment and intervention, like you were saying, you know, like and it's dangerous, but it still needs treatment because 1,000 other kids who had an argument with their mom didn't take pills in front of their mom tonight. It meets that level of like, okay, there's something more going on that they need help being supportive with. And like Julie had said, kind of in comments here, they're just trying to get their needs met. Okay, thanks, Nina. Jump in anytime again, because I'm about done, I think. So the last slide after this is team considerations. So other people might call this burnout, other people might talk about this, but I'm going to acknowledge what might be the elephant in the room. It's not the elephant in the room in my department because we just openly talk about it, that emergency departments really struggle with psychiatric patients for many different reasons. A lot of us got into it to do crisis work, to fix something and move on, to not have the long-term relationships, to not remember to give scheduled meds and remember what time breakfast is and did you take a shower today? Because I have other patients over here who can't breathe, right? So I think there's that of like, oh, there's so many priorities. It's really hard to have this ongoing, and I can't fix this right now. Like a lot of times it's that feeling of inadequacy of like, what is my role in this right now? They need help, yes, and I don't know what to do. So I think a lot of times there's that resentment towards kids coming in who have the psychiatric presentations. A lot of it is, and lack of training. I wasn't trained on this. I don't know. I need someone to come in and help. Or a feeling of inadequacy of what is my role here? I don't know how to get this kid to stop being angry and I need to do my job. So someone like, how do I do this? I'd rather not be in this, you know, taking care of this room. And then the moral distress. If you strongly feel like, what are we, you know, kind of feeling overwhelmed with like, I don't think the kids should be in this department. I feel like, what are we doing to them? Are we hurting them more than helping them? It really can bring on a lot of those feelings from team members. And so coming at it with our teams in the same way that we're talking about supporting our patients and families, making sure they have opportunities to talk and debrief that's judgment-free. And then we can, you know, reframe and talk to them about what's going on. And giving them structure and predictability as well, creating these pathways, giving them the trainings, helping know who the experts are, who are their resources, they're not in it alone. I think that's one of the things with this crisis that we're in is it does feel very like we are the emergency departments are the ones who can't say no. So everyone who doesn't know what to do sends their kids to the emergency department for these psychiatric crises, and then no one has to take them. And so I think is feelings that are real in the emergency departments. And part of it is our jobs, all of your jobs as well, as helping support staff own that feeling. Like they didn't go into psych, so why are they doing this? But at the same time, these kids are in crisis, as Nina was saying, like they have a need. We have a specialty that can help them. We just need additional support and structure and predictability of here's what I'm supposed to do. And that hasn't been created in a lot of emergency departments in the past before this became more of a crisis. Okay, so I think this, next slide. Here's some of the resources of kind of the different websites that talk about trauma-informed care and the different things that I had mentioned before. Next slide. Okay. So I think I pass it on to you, Kate, for Q&A.
Thank you both so much. I mean, what a powerful conversation that you've led us through. Some really nice comments in the chat just about how beautiful that book is, Nina, and also appreciation for the inclusion of trauma-informed care. My hope is that there's so many great takeaways from this in terms of how you think about the clinical care pathways and ED-based interventions to really integrate some of this into your standardized processes. I love the conversation around culture changes. One of the comments in the chat, and maybe this is for both Angela and Nina, is just around the inclusion of trauma-informed care. Do you have ideas, thoughts, suggestions, resources about how staff might undergo additional training related to that so it can be better integrated in their day-to-day processes?
So in the resources that I had, the National Council, I think it was for Trauma, the top one, has some trainings on trauma-informed systems in the healthcare. A lot of time, so that has a lot of language speaking directly to medical providers. A lot of it has to do with also just medical trauma and the impact that it has on kids in general. But we use that to create trauma-informed care training for our team members. SAMHSA also has a lot of information. I think it's the University of Buffalo School of Social Work has like a trauma-informed care like training manual that goes through and says, here's how you assess where you're at. Here's different steps to meet. So those would be some of the first ones that I go to. They're in general, the Council on Mental Wellness, I think they have some trainings as well around that. Not as many that speak directly to emergency departments, but just on the concept of trauma-informed care.
When I first started working in the emergency department, the as I said, my training in child life didn't include a lot of mental health, and trauma-informed care is great for any population of patients, but I really sort of started following all of the emergency departments around the city to see what their departments were putting out as far as trainings. So that's another really great way to get, like, that was how I kind of did. There was like the on-the-job training, and then there was the, okay, what are other ERs? What are pediatric ERs? What are bigger programs? What are different programs doing? Because a lot of the times, that was where some of like my best education came from, was from other local. I mean, I'm in New York, so I understand that's not everyone's local network isn't as like robust, but people are putting these out there.
Mm-hmm. Yeah, as you said that was one of the first things I did a long time ago as well. And I think CHOP had done an initiative and had some trainings online as well. So I think that's a great point.
Perfect. Well, thank you both. I think at this juncture, we'll go ahead and launch the poll. And while we're doing that, if there are others who have questions, feel free to enter those into the Q&A feature, and we will work to address those during the last few minutes. We appreciate you all being here, and really appreciate Nina and Angela, you sharing those ideas and resources. It would be amazing if all these other emergency departments began creating books like you have, Nina. I'm just thinking about ways that we can ensure routines and schedules and predictability are integrated into the everyday work. So thank you all.
I think especially in the emergency room, especially as a child life specialist, someone will say, well, can you make a schedule? And the truth is, on your 4th day of boarding, when you can't have any kind of technology and I can't we don't have access to outdoor space or even the promise of a shower every day. That's really hard. So even just like that, what that binder has done is it's created a shared experience. And like, there's a lot of value in that. Like, a lot of the entries are very inspirational, but a lot of them are talking about the same things that they're frustrated by. So people feel very validated in like the lack of things that we can provide. And it's been kind of almost it's helped us like get access to a shower, like taking that book to hospital administrators and being like, look at all of these entries of these kids that are struggling, and now they're building us a shower. So it was great in a lot of ways, but you know, what you can't do with like something like that, which is just a patient's experience, really does shine quite the light on what's needed, in addition to a better system in general, like in this country for this.
Thanks for that. You know, I think so much of what we do in pediatric emergency care is advocacy, especially within general hospitals, if that's where we work. So these ideas of how you can use patient and family-centered feedback, satisfaction, more focused feedback like you're getting to advocate for them is a great idea. So again, thanks for all of you for joining. Thanks for all of you for entering your evaluation into the poll. We are nearing the end of today's talk. I don't see any other questions entered into the Q&A. I am going to go ahead and post the CE links for nurses and social workers, and I think we will also be adding those into the chat for you to click on directly if you don't use the QR code. Again, this talk will be posted to the website along with the slides. Angela and Nina, we're so grateful for your expertise in this area. This was really just a powerful talk, and we appreciate you sharing your knowledge with us. So thank you everyone for joining today, and we will see you next week for our next learning session. We're really excited to have our first breakout groups. We'll be getting to hear a little bit more from each of you and your teams about who's on your team, about your site, and about what you're hoping to accomplish over the coming months. So thank you again for joining today.